Okay. All right. So a very good evening, everyone. Yes. So just give me a quick response. So a very good evening, everyone. Yes. So just give. All right. So I hope I'm audible and visible to all of you. All right. Great. So now in this particular session, we'll try to. Yes. So this is a very big day for entire India. So election results today. So but we have our own targets to finish. So today we'll try to finish the remaining topics, but the topic which I'll be starting first today will be the neurology, right? So I have already sent the PDF on my Telegram channel, right? So that my Telegram channel, it is Medicine Made Easy by Dr. Rajesh Gubba. So on this Telegram channel, I have already sent the PDF. So you can download the PDF from this Telegram channel, right? Okay. Right. Yes, VPR, I wish you a very happy birthday, VPR. Great. Now let us start with the session. So these will be the topics for the today's session in the neurology. Guillain-Barre syndrome, myasthenia, Lambert-Eaton myasthenic syndrome, motor neuron disease, Parkinson's, meningitis, migraine, epilepsy, multiple sclerosis, cerebrovascular accidents, spinal cord disorders, and cranial nerve disorders, right? Now, let us start with the first topic, that is the Guillain-Barre syndrome. So, the first question is, which of the following are the regions where damage is seen in the demyelinating polyneuropathy type of the Guillain-Barre syndrome? That is the first question. Axons and Schwann cells, dendrites and nucleus, cell body and nucleus, dendrites and the cell body. Yes. Anyone? A quick response. Let us concentrate on our quick revision program rather than the election results. Yes, we are all definitely responsible persons. Great. So the part of the part of the neuron which is being damaged in the demyelinating polyneuropathy of the Guillain-Barre syndrome, it is the axons and as well as the Schwann cells, right? Now, we have the subtypes in Guillain-Barre syndrome, that is the AIDP, that is acute inflammatory demyelinating polyneuropathy, acute motor axonal neuropathy, then acute sensory motor axonal neuropathy, and then the Miller-Fisher syndrome. But out of all these, the most common type is the AIDP, that is acute inflammatory demyelinating polyneuropathy is the most common type, right? Now, what exactly will be the pathogenesis in this is, it is, in case of AIDP, it is immune-mediated attack on the peripheral nerve. And which part of the peripheral nerve? That is the myelin. And what are the antibodies that you will have in case of the AIDP, that is acute inflammatory demyelinating polyneuropathy? Yes, can anyone tell me what are the antibodies in case of the AIDP? So the antibodies are the anti-GM1 antibodies, right? Whereas acute motor axonal neuropathy, as the word itself tells you, it is only the motor component which is being defective, okay? So here, there is no sensory component in case of acute motor axonal neuropathy. And the antibodies are also the same, that is anti-GM1 antibodies. Then we have acute sensory motor axonal neuropathy. So you have the sensory loss and as well as the motor loss. And here also the antibody, it is the same, that is the anti-GM1 antibody. Then followed by that, we have the Miller-Fisher syndrome. Miller-Fisher syndrome, this is one of the rare type of rare variant of the Guillain-Barre syndrome, right? And in these individuals, the sensory loss, either it is minimal or completely absent. But the antibody in case of Miller-Fisher syndrome, it is quite different than compared to that of the AIDP, AMAN, and as well as the ASMAN. What is the antibody here is, it is the anti-GQ1 antibody that you have in case of the Miller-Fisher syndrome. And in case of the Guillain-Barre syndrome, what exactly will be the feature? It is acute flaccid paralysis, which is ascending type of paralysis, right? Now, we'll try to take up the question on the Miller-Fisher syndrome. Yes, can anyone answer this? Which of the following best describes the characteristic triad of the symptoms seen in the Miller-Fisher syndrome? Yes, great. So the characteristic triad, right? Very good, Pranav Mohanan. So the characteristic triad will be that these individuals, they'll have ptosis, they will have ophthalmoplegia, and as well as the areflexia, that is absent reflexes, right? And when these three components are present, that is all suggestive of the Miller-Fisher syndrome. And what are the antibodies in case of Miller-Fisher syndrome? The antibodies in case of Miller-Fisher syndrome will be the anti-GQ1 antibodies. The antibodies will be anti-GQ1 antibodies. Now, that was about the variants of the Guillain-Barre syndrome. Now, you also need to know what exactly is the underlying etiology that is causing the Guillain-Barre syndrome. Now, you see this question. We have a 32-year-old male presents to the emergency department with weakness and numbness in his legs. That has progressively worsened over the past few days. He reports having diarrheal illness approximately 4 weeks ago, which resolved without a specific treatment. On examination, the patient is noted to have decreased deep tendon reflexes and the ascending paralysis. Which of the following etiological agent is the most commonly associated with this condition? Yes, COVID-19, Zika virus, Campylobacter jejuni, and as well as the Epstein-Barr virus. Right. So in case of Guillain-Barre syndrome, if it is occurring secondary to the diarrheal illness, please remember the organism is the Campylobacter jejuni. So actually, the antibodies which are formed against the Campylobacter jejuni, that will cross-react with the myelin sheath. Right? That will cross-react with the myelin sheath, causing demyelination. That is what is observed in case of the Guillain-Barre syndrome. Then, what is this pathogenesis called as? This particular pathogenesis, this is called as the molecular mimicry. Right? So this pathogenesis is called as the molecular mimicry. Now, what about the other organisms that will be causing Guillain-Barre syndrome apart from the Campylobacter jejuni? Even COVID-19 will cause the Guillain-Barre syndrome. Zika virus will also cause the Guillain-Barre syndrome, particularly in the pregnant women. And even Epstein-Barr virus also will cause the Guillain-Barre syndrome. Then even the other important viruses like hepatitis E virus can also cause the Guillain-Barre syndrome. Okay. And even vaccination, that is rabies vaccination, can also lead to the development of the Guillain-Barre syndrome. Right. But why the answer is Campylobacter jejuni? Because this important terminology, that is diarrheal illness, is the one which gives us a clue that the answer is the Campylobacter jejuni as the organism, right? Then what exactly is the investigation of choice? What will be the clinical features? Ascending type of paralysis will be there in Guillain-Barre syndrome. And the earliest manifestation in Guillain-Barre syndrome will be loss of deep tendon reflexes, right? And in patients with the Guillain-Barre syndrome, you need to understand that the cause of death will be respiratory failure. Why there will be respiratory failure? That is because of the respiratory muscle paralysis that will happen in 5% of patients. And the investigation of choice will be the antibodies, that is anti-GM1 in the AIDP and anti-GQ1 in case of Miller-Fisher syndrome. And when you do a nerve conduction studies, that will show you a demyelinating pathology, right? That will show you demyelinating pathology. So can anyone tell me what is the drug of choice in case of Guillain-Barre syndrome? What is the drug of choice in case of the Guillain-Barre syndrome? Drug of choice in case of Guillain-Barre syndrome will be the intravenous immunoglobulins. That will be the drug of choice in case of the Guillain-Barre syndrome, right? So that was about the story related to the GBS, right? Now, we'll take the next topic in the neurology, that is the myasthenia gravis. And apart from IVIG, what is the other alternative treatment? The other alternative treatment for the Guillain-Barre syndrome will be plasmapheresis. But please remember, there is no role of corticosteroids in the treatment of the Guillain-Barre syndrome, right? Next, the next topic for the discussion will be the myasthenia gravis, right? So you take this question. We have a 45-year-old woman presents to the neurology clinic with complaints of the progressive muscle weakness, particularly in her facial and as well as the proximal limb muscles. She reports difficulty in swallowing and speaking, which worsens throughout the day and improves with rest. On examination, the patient demonstrates ptosis, diplopia, generalized weakness. All of the following are the antibodies seen in this condition except anti-acetylcholine receptor antibodies, anti-MuSK antibodies, anti-LRP4 antibodies, anti-netrin-3 receptor antibodies. Right. Yes. Very good. So this entire clinical picture. So the individual weakness is worsening throughout the day and improves with rest. So this point is suggestive that it is a clinical diagnosis of the myasthenia gravis. And in myasthenia gravis, you need to know what are the antibodies. The anti-acetylcholine receptor antibody will be there, anti-MuSK antibody will be there, and anti-LRP4 antibody will be there. But it is not anti-netrin-3 receptor antibody, it is anti-netrin-1 receptor antibody. It is anti-netrin-1 receptor antibody. So now this is the list of the antibodies that you will have in case of the myasthenia gravis, right? So among all these, the very important antibody is what? That is anti-acetylcholine receptor antibody. This is present in almost 85% of patients, right? Whereas anti-MuSK antibody, this is present in case of only 10% of the individuals where the acetylcholine receptor antibody is negative. Then you take this anti-LRP4. This will target, what do you mean by the word LRP4? That stands for low density lipoprotein related protein 4. Low density lipoprotein related protein 4. That is what is your anti-LRP4. Then next is anti-netrin-1 receptor antibody will be there. It is not anti-netrin-3. The other antibody is the anti-Caspr2 antibody that will target contactin associated protein like 2. Then we have the anti-striated muscle antibody that is that is targeted against the striated muscle protein. So these are the various antibodies that we have. Yeah, Philadelphia. I'll also tell you about Lambert-Eaton myasthenic syndrome also. Okay. So these are all the various antibodies that you have in case of the myasthenia gravis, right? Now, you see the next question. Which of the following is not the clinical feature of the myasthenia gravis? Which of the following is not the clinical feature of the myasthenia gravis? Yes. So, aspiration risk, oropharyngeal dysphagia, proximal muscle weakness, deep tendon reflexes, not preserved. Right. No, Shravanti Kodali, aspiration risk will be there in these patients. Why? Because these patients with myasthenia gravis, they will develop respiratory failure. So once they develop respiratory failure, there will be aspiration risk. And oropharyngeal dysphagia will also be there, and proximal muscle weakness is more common than compared to that of the distal muscle weakness. All right. And what is the earliest manifestation is? The earliest manifestation in patients with myasthenia gravis is ptosis. And that too, it is asymmetrical ptosis. That is what you will observe in case of the myasthenia gravis. And the ptosis is mainly due to the involvement of which muscle? That is levator palpebrae superioris muscle. And what about the deep tendon reflexes? Remember, the deep tendon reflexes, they are preserved in patients with the myasthenia gravis. They are preserved. Now, let me just quickly discuss about the myasthenia gravis. Myasthenia gravis, this is an autoimmune disorder. And this is more common in females rather than males. And what type of hypersensitivity reaction is your myasthenia gravis is? It is type 2, but within the type 2, we have a subtype. And what is the subtype of type 2 hypersensitivity reaction? That is type 5. And if you take the etiology of the myasthenia gravis, it is mainly the thymus gland abnormalities. What will be the thymus gland abnormalities is thymic hyperplasia, this will be like much more common than compared to that of the thymoma, resulting in the development of the myasthenia gravis. And they have the HLA association, right? The HLA association in myasthenia gravis is the HLA B8, right? So this is HLA B8. Okay, that will be the HLA association in case of the myasthenia gravis. Okay, and the pathogenesis is the antibodies, they are formed against the postsynaptic nerve terminal. Because the antibodies are formed against the postsynaptic nerve terminal, what will happen? The neuromuscular transmission does not occur, but the neurotransmitter is present in adequate quantities, and the earliest manifestation will be ptosis, and that too the asymmetrical ptosis will be there, right? And the other features will be these individuals will have weakness in the facial muscles, weakness in the masticatory muscles, weakness in the deglutition muscles, and weakness in the lingual muscles as well, right? And the deep tendon reflexes, they are preserved in these patients, right? And proximal muscle weakness will be more common than compared to that of the distal muscle weakness. And what is the cause of death in these patients? That will be respiratory failure. And we have a terminology called the ocular myasthenia gravis. What is this ocular myasthenia gravis? It is characterized by a triad, which includes ptosis. There will be also diplopia, and then the orbicularis oculi weakness. And in case of the ocular myasthenia gravis, the antibodies will be the anti-MuSK antibodies in ocular myasthenia gravis. Whereas in generalized myasthenia gravis, what is the investigation of choice? The investigation of choice will be the single fiber electromyography, right? Single fiber electromyography, right? And what is the treatment of choice in case of the myasthenia gravis is thymectomy. Thymectomy is the treatment of choice. What is the drug of choice in case of mild myasthenia gravis? That will be pyridostigmine, or which we also call it as pyridostigmine or physostigmine. Whereas the drug of choice in case of the severe form of myasthenia gravis will be the steroids. And what is the drug of choice in case of the myasthenic crisis? We give intravenous immunoglobulins. So this is about your myasthenia gravis, right? Now the ptosis will be the asymmetrical ptosis. And how can you demonstrate this ptosis? By doing the continuous upward gaze. Sustained up gaze will induce the development of the ptosis. And these patients, they have a characteristic smile, and that we call it as the myasthenic snarl. And that is because of the weakness of the facial muscles, right? Then, so coming on to the next question, right? A 45-year-old woman presents to the neurology clinic with complaints of intermittent double vision and drooping of her eyelids, particularly worsening in the evening. She also reports generalized fatigue and weakness, especially after prolonged activity. On examination, the patient demonstrates bilateral ptosis and limited eye movement. Which of the following is the mandatory test that should be done in this patient? CT or MRI of the head, CT of the chest, IcePack test, anti-acetylcholine receptor antibodies. Okay, so here, right. No, I did not get the correct answer from any one of you. See, the point here is very clear. What is that? There is like intermittent double vision and as well as the drooping of her eyelid, right? Okay. Now, the patient is also complaining of generalized fatigue, and weakness, especially after the prolonged activity, and demonstrates the bilateral ptosis and limited eye movement. And if you are suspecting myasthenia gravis, in myasthenia gravis, what will be the type of ptosis that we have discussed in myasthenia gravis? Is it symmetrical ptosis or asymmetrical ptosis in myasthenia gravis? In myasthenia gravis, like we have discussed that these patients, they will have the asymmetrical ptosis more commonly. Very rarely they will have bilaterally symmetrical ptosis, right? Okay. Now, what is here that you need to do is the CT or MRI of the head. Why? Why is that you are doing CT or MRI of the head? See, the CT or MRI of the head, it is mainly to rule out the structural abnormalities, right? That is mainly to rule out the structural abnormalities that are compressing the cranial nerves, that are causing the ocular manifestations, that is ptosis and as well as the ophthalmoplegia. So thereby we will be able to pick up if there is any brain tumor, if there is any vascular abnormality like AV malformation, if there is any presence of intracranial space occupying lesion. Okay. Whereas all the remaining three tests, they are very much suggestive of the myasthenia gravis, right? But the point like bilateral ptosis, that is giving us a little confusion whether it is myasthenia gravis or some other underlying etiology. So because the suspicion of the cerebrovascular accidents are more common than compared to that of the myasthenia gravis, right, in the general population also. So first you need to rule out that, and if that is being negative, then you can do this ISPAC test and as well as the anti-acetylcholine receptor antibody. Okay, because we are discussing the myasthenia gravis topic, it doesn't mean that we do this ISPAC test or anti-acetylcholine receptor antibody first. Okay, so don't just have only a narrowed thought, right? Completely a broad thought. And that one point which is making us to think that it is not myasthenia, it is bilateral ptosis. Okay, right. And you take this ISPAC test, right? So what is the reason why we do this ISPAC test? The ISPAC test is the one which will improve the ptosis. You apply the ISPAC, there will be improvement of the ptosis. Why there is improvement of the ptosis? Because application of the ISPAC will increase the neuromuscular transmission. Right, will increase the neuromuscular transmission. So whenever you apply the cold temperature, what will happen is there will be decrease in the enzymatic activity of acetylcholine esterase activity. Once the enzymatic activity is increased, then there will be increase in the levels of the acetylcholine. Once there is increase in the levels of the acetylcholine, that will increase the neuromuscular transmission. Okay, so that is about the ISPAC test. And the antibodies, if you observe, the antibodies are positive only in 85% of patients. That is the reason why your anti-acetylcholine receptor antibody is not considered as the investigation of choice, right? Next. A 30-year-old female who is known case of myasthenia delivered a baby by LSCS. Okay. During breastfeeding the baby, the mother experienced regurgitation of milk and choking episodes in the baby. Which of the following is the drug of choice for this condition? Physostigmine, neostigmine, edrophonium, azithromycin. So what do you think is the drug of choice here? So what drug you want to give to the baby? Pranav Mohanan, remember what exactly is this baby suffering with? This particular baby, right, is suffering with neonatal myasthenia gravis. Right, suffering with neonatal myasthenia gravis. And you have to know that in neonatal myasthenia gravis, it is not physostigmine that is the drug of choice. In neonatal transient myasthenia gravis, the neostigmine is the drug of choice. Neostigmine is the drug of choice. Very good, Dr. Philadelphia, right? You have answered it correctly. So the answer is, so please remember neonate, neostigmine. So that way you can remember for, whereas physostigmine is the drug of choice in case of generalized myasthenia gravis, but not in case of the neonatal myasthenia gravis. And this edrophonium test is for what? This is for diagnosis of the myasthenia gravis, but not for the treatment. And azithromycin, right? This is not used in the treatment of myasthenia gravis at all. Okay. So that was the story related to myasthenia gravis. Now, let me discuss about the Lambert-Eaton myasthenic syndrome. So, yes. We have a 55-year-old male presents to the neurology clinic with complaints of progressive muscle weakness, particularly in the proximal muscles of his limbs, dry mouth and constipation. He reports difficulty in standing up from the seated position and lifting objects. On examination, the patient demonstrates reduced deep tendon reflexes and fatigability upon repeated muscle testing. All of the following are true about the syndrome except it is a paraneoplastic syndrome of coat cell carcinoma, Lambert-Eaton postjunctional, deep tendon reflexes are reduced, drug of choice is 3,4-diaminopyrimidine. Right. So, Lambert-Eaton myasthenic syndrome, it is associated with the paraneoplastic syndrome, that is coat cell carcinoma. And where exactly will be the site of defect in case of Lambert-Eaton myasthenic syndrome is, it is not the postjunctional, it is prejunctional. Okay, where the antibodies, they are formed against the voltage-gated calcium channels which are present on the presynaptic nerve terminal. And in case of the Lambert-Eaton myasthenic syndrome, the deep tendon reflexes are reduced, and drug of choice is 3,4-diaminopyrimidine, right? And what will happen to the levels of Lambert-Eaton myasthenic syndrome at the synapse? It will be reduced. Whereas in case of myasthenia gravis, the acetylcholine levels will remain normal. And in myasthenia gravis, the earliest muscle which is affected is levator palpebrae superioris, whereas the earliest muscle which is affected in Lambert-Eaton myasthenic syndrome will be the proximal muscles are commonly affected then compared to that of the distal muscles. Okay, so rather than your levator palpebrae superioris muscle. And deep tendon reflexes will be reduced in the patients with the Lambert-Eaton myasthenic syndrome, right? And how is that you will be able to diagnose? That is by repetitive nerve stimulation test. Repetitive nerve stimulation test will show you that there is decremental response, right? Repetitive nerve stimulation test will show you that there is decremental response, right? And what exactly is the drug of choice? That is 3,4-diaminopyrimidine, which will increase the neuromuscular transmission. Okay, so the answer here is the Lambert-Eaton myasthenic syndrome is post-junctional is a wrong statement. It is a pre-junctional, right? Then coming on to the next topic, that is motor neuron disease. So in motor neuron disease, right? So you see here, we have a 55-year-old male presents to the neurology clinic with progressive weakness and muscle atrophy in his limbs. He reports difficulty in performing daily activity such as right. Yeah. So I'm very sorry, VPR. In case of, I'm very sorry. Yeah, you're right. In case of myasthenia gravis, the repetitive nerve stimulation will show you that there is decremental response. Whereas in case of the Lambert-Eaton myasthenic syndrome, you will have the incremental response, right? Yeah, thank you, VPR. Right. Now coming to the topic of the motor neuron disease. So we have a 55-year-old male presents to the neurology clinic with progressive weakness and muscle atrophy in his limbs. He reports difficulty in performing daily activities such as walking and as well as lifting the objects. Upon examination, the patient exhibits the muscle fasciculation and as well as the hyperreflexia. All are the factors contributing to the pathology of this condition except defective protein degradation in the neuron, defective RNA processing, increased glutamate levels, increased methionine levels. Yes. Anyone? So which of the following is not the suggestive of the pathology related to the condition which has been described above? What is the condition which has been described above? So the patient is having hyperreflexia, which is an upper motor neuron sign. The patient is also having fasciculation, which is a lower motor neuron sign. And the patient is also having muscle atrophy, which is a lower motor neuron sign. So you have a mixture of both upper motor neuron and as well as the lower motor neuron. So this is a clinical scenario suggestive of the amyotrophic lateral sclerosis. And in case of amyotrophic lateral sclerosis, you have defective protein degradation in the neuron. And there is defective RNA processing. There is also increase in the glutamate levels. But please remember, there is no increase in the methionine levels. There is no increase in the levels of methionine in the pathology of the amyotrophic lateral sclerosis. And what will happen to the aspartate levels? The aspartate levels, they are increased in patients with the amyotrophic lateral sclerosis. So this will be the pathology in case of the ALS. And if you take this motor neuron disease, we have three forms, right? What are these three forms of the ALS? The three forms of the ALS is three forms of motor neuron disease is the one with upper motor neuron and as well lower motor neuron. That will be amyotrophic lateral sclerosis, right? Whereas predominantly upper motor neuron, that is primary lateral sclerosis, right? And predominantly lower motor neuron involvement, that is the SMA, that is spinomuscular atrophy, right? And this will be the various forms of the motor neuron disease. But the most common among all these will be the amyotrophic lateral sclerosis. And what is the important risk factor for the development of amyotrophic lateral sclerosis is smoking is a very important risk factor, right? And next is You need to be aware that in patients with motor neuron disease, there is no sensory symptoms at all. It will be only motor manifestations, right? And will there be any bladder and bowel involvement? There is no bladder and bowel involvement. And at the same time, there is no pseudo hypertrophy, right? And at the same time, there is no pseudo hypertrophy in case of the amyotrophic lateral sclerosis. And what will happen to the ocular motility? The ocular motility, it is completely spared in these patients, right? Ocular motility is spared in patients with the amyotrophic lateral sclerosis. And even the higher mental function also will be normal. And what is the most common pathognomic symptom? That will be the fasciculations. Fasciculation is the most common symptom, right? So that is about the story related to 1 minute. Right. So that will be story related to the motor neuron disease, right? Or the amyotrophic lateral sclerosis. Then you see another question in the workup of the amyotrophic lateral sclerosis. A 35-year-old male presents with weakness persisting for 3 months, accompanied by the tongue fasciculations, 4+ deep tendon reflexes at the knee, muscle atrophy in certain regions alongside spasticity. Which additional test is warranted for this patient considering the suspected amyotrophic lateral sclerosis? So basically, like, the question is, what is the investigation of choice in patients with the amyotrophic lateral sclerosis? Yes. What is the investigation of choice? So if you take the investigation of choice in these patients with amyotrophic lateral sclerosis, no. It is not MRI of the whole spine. So the investigation of choice in the or first line investigation will be the electromyography. That will be electromyography. That is how you will be able to diagnose amyotrophic lateral sclerosis, right? Then followed by this electromyography, the next important investigation is peripheral nerve conduction studies. Right? Peripheral nerve conduction studies. Okay, so this is how you will be able to diagnose the amyotrophic lateral sclerosis, right? Then we will discuss the treatment of the amyotrophic lateral sclerosis, right? A 20-year-old male was brought to the clinic by his parents with complaints of weakness in his legs for 1 day. On examination by the physician, he had fasciculations, a slapping gait, absent knee jerk in one leg, and brisk biceps jerk. The doctor advised EMG, which showed the denervation pattern in the LMN involved. Which of the following is not the treatment used to manage this condition? Physiotherapy, finger extension splint, tracheostomy, steroids. Yes. So now, this condition is what you are having upper motor neuron. What are the upper motor neuron signs here? The upper motor neuron signs is brisk biceps jerk. That is an upper motor neuron sign. What are the lower motor neuron signs? Fasciculation is a lower motor neuron sign. Yeah, right. And slapping gait, that is because of the peripheral nerve lesion. That is also a lower motor neuron sign. And absent knee jerk, that is also a lower motor neuron sign. So the patient is having both upper motor neuron and as well as the lower motor neuron findings, which is suggestive of the amyotrophic lateral sclerosis. And in amyotrophic lateral sclerosis, physiotherapy is important. Finger extension splint is important because of the peripheral nerve lesion. And tracheostomy is also required. But when is the tracheostomy required? Whenever there is involvement of the respiratory muscles, then the tracheostomy is required. But please remember, the steroids, they have no role in the treatment of the amyotrophic lateral sclerosis. And at the same time, you need to know the drugs which are approved for the treatment of amyotrophic lateral sclerosis. We have two important molecules. One is the riluzole, and the other important molecule is the edavarone. So riluzole and as well as the edavarone, these are the important medications which are given in the treatment of the amyotrophic lateral sclerosis. They will prevent the progression of the amyotrophic lateral sclerosis. Okay, so this is about the story of the treatment of the ALS. Then, right. Now, after having finished about the ALS, the next two questions is about the bulbar palsy and as well as the pseudobulbar palsy. Yes. Which of the following nerves are affected in case of the bulbar palsy? 9, 10, 11, 12, 9, 10, 11, 7, 9, 11, 9, 10, 12. Yes. Which of the following nerves are affected in the bulbar palsy? So if you see the nerves which are affected in the bulbar palsy, right? So you have the involvement of 9, 10, 11, and as well as 12. These are the nerves which are affected in case of bulbar palsy, right? And these are the cranial nerve nuclei which are present in the medulla oblongata. These are the cranial nerve nuclei which are present in the medulla oblongata and they are damaged. And your bulbar palsy is what? It is an LMN palsy. Whereas you take pseudobulbar palsy. Pseudobulbar palsy, it is an UMN palsy. And you will have the clinical features accordingly. So if you have damage to the ninth nerve, there will be difficulty in swallowing, right? And if there is damage to the 10th nerve, there will be difficulty in voice production, that is phonation. If there is damage to the 11th nerve, there will be weakness of the sternocleidomastoid and trapezius. And if there is damage to the 12th nerve, there will be difficulty in controlling the movements of the tongue. Okay, so this will be 9, 10, 11, 12 palsy in the bulbar palsy. Next, which of the following statements about the pseudobulbar palsy is accurate? Typically presents with a monotone voice and reduced emotional expression, diminished gag reflex, anarthria is a feature of pseudobulbar palsy, exaggeration of emotions such as involuntary crying or laughing is a characteristic feature. Pseudobulbar palsy is accurate. No, so you don't have the reduced emotional expression in case of the pseudobulbar palsy. There are exaggerated emotional expression in case of the pseudobulbar palsy. And the gag reflex will not be diminished. There will be exaggerated gag reflex that in case of pseudobulbar palsy, right? And if you take the speech in these individuals with pseudobulbar palsy, we describe this speech as the Donald Duck voice, right? Donald Duck voice. And what do we describe this as? This we describe it as dysarthria. There will be dysarthria. And they will have the exaggerated emotions like involuntary crying and as well as laughing. So this will be the features of the pseudobulbar palsy. Number one, it is, and the degeneration is what? Upper motor neuron. And what is that upper motor neuron that is being affected? That is the corticobulbar tract is being affected. Okay. And they will have dysarthria, they will have exaggerated emotions, and they will have brisk gag reflex. Okay. So that was about the discussion related to bulbar and pseudobulbar palsy and motor neuron disease. The next topic for the discussion will be Parkinsonism. So, yes, which of the following correctly differentiates Alzheimer's from the Parkinsonism? Low dopamine levels, presence of the Lewy bodies, damaged nucleus of Maynard basalis, decreased thalamic activity. Yes, right. So here, almost actually all of these, they are the differences between Alzheimer's and Parkinsonism. But yes, very good VPR. So it is damage to nucleus of Maynard basalis. This is the very important point of difference between the Alzheimer's and as well as the Parkinsonism. See, in which scenario you have damage to the nucleus of Maynard basalis, that is in case of the Alzheimer's. In Alzheimer's, the question asked is what? Differentiates Alzheimer's from Parkinsonism. Whereas low dopamine levels, they are the feature of the Parkinsonism. Presence of the Lewy bodies, that is also the feature of the Parkinsonism. Right? Decreased thalamic activity, that is also the feature of the Parkinsonism. But what is the question asked? The question asked is, how will you differentiate Alzheimer's from Parkinsonism? So in Alzheimer's, you don't have low dopamine levels. In Alzheimer's, you don't have Lewy bodies. In Alzheimer's, you don't have decrease in thalamic activity, right? So the answer here is what? the nucleus of Maynard basalis is what is damaged in case of Alzheimer's. And this particular table is an important table of differences between Parkinson's and Alzheimer's. In Alzheimer's, you have less acetylcholine. In Alzheimer's, you have nucleus of Maynard basalis being damaged, whereas in Parkinsonism, substantia nigra is being damaged. And in Alzheimer's, you have the Hirano bodies which are being present, right? Whereas Lewy bodies in Parkinson's. And the protein in the inclusion bodies, if you observe, tau protein is present in Alzheimer's, whereas alpha-synuclein protein is present in Parkinsonism. And activity of thalamus is decreased in Parkinsonism, and activity of globus pallidus interna increases in Parkinsonism. Okay. Yeah, Sangi. Hydrophonium test is nothing but the tensilon test. Right? And what is the purpose of this hydrophonium test or tensilon test? That is mainly to diagnose myasthenia gravis. We do this particular hydrophonium test or the tensilon test, right? So this is about the differences between Parkinsonism and as well as the Alzheimer's. Now, if you take the discussion related to the Parkinsonism, we have a 75-year-old banker complains of increased difficulty in buttoning his shirt every morning, brushing his teeth. He states that his hand shakes while relaxing in front of the TV, but stops while reaching for the remote and switching the channels. Which of the following is the next most appropriate step in managing this patient? Deep brain stimulation, sending him for cognitive behavioral therapy, prescribe levodopa, and then prescribe memantine. Yes. So this entire clinical picture is suggestive of what? Parkinsonism. Difficulty in buttoning, difficulty in brushing, his hand is shaking in it. That means this is what? Resting tremors basically. Right. So the correct answer here is you need to prescribe levodopa. So levodopa, it is the first line treatment in patients with the Parkinsonism. Right. And this particular levodopa, what is the mechanism of action? It will replenish the levels of dopamine in the body. It will replenish the levels of the dopamine within the brain. Okay. And this particular levodopa will also improve the patient's quality of life. Quality of the life is also increased. Now, if you take the important points in Parkinsonism, they will have the resting tremors of the frequency 4 to 6 hertz. Rigidity, it will be lead pipe rigidity in the lower limbs and the cogwheel rigidity in the upper limbs. And the postural reflexes are not preserved, thereby they will be having frequent falls. The description of the gait is the festinate gait. There will be slowness of movement, that is the bradykinesia. And if you take the handwriting of these individuals, they will have micrographia, right? They become small and spidery. And there will be loss of expressions within the face. That is called expressionless face. And the deep tendon reflexes, they are unaltered. Plantar reflex, it is flexor response. And Meyerson sign is being present. So these are the important findings in case of the Parkinsonism. But can anyone tell me what is the earliest clinical manifestation in patients with Parkinsonism? What is the earliest clinical manifestation in patients with the Parkinsonism? So the earliest clinical manifestation, it is not tremors. The earliest manifestation, yes, very good. So it is not tremors. So it will be constipation, right? It will be constipation, followed by that development of the anosmia. Followed by the development of the anosmia. This will be the early manifestations. So these manifestations, they precede the motor symptoms. But if the question is asked, what is the earliest motor manifestation? The earliest motor manifestation will be the resting tremors, right? So that is about the treatment. That is about the features related to your Parkinsonism. Yeah, Shubham Kumar, I'm discussing the treatment. I have another questions related to the treatment. I'll come to your memantine in that. Yeah, so this is called as the wheelchair sign of Quinn. This is nothing but wheelchair sign of Quinn. So because of the complete loss of postural reflexes, they are confined only to the wheelchair. They are not able to get up. Whenever they get up, they immediately fall. They immediately fall. Okay, right. Now, okay, if you take these options, when do you use this deep brain stimulation? Deep brain stimulation is done when medical management fails. When medical management fails, deep brain stimulation has to be given, right? And cognitive behavioral therapy, it has no role in improving Parkinsonism symptoms. Right? Whereas you take memantine, it is not the drug for Parkinsonism. It is the drug for the Alzheimer's. Right? Yes, Shubham, is that clear? The memantine is a drug which is given in the management of Alzheimer's disease and other forms of dementia, right? But not in case of the Parkinsonism, right? So that was about the story related to the treatment part. Then, yes, we have a 65-year-old male patient presents with the history of the Parkinson's disease, presents to the neurology clinic for a follow-up visit. He has been on levodopa therapy for several months, and the clinician is discussing potential side effects of the medication, except dyskinesia, nausea, orthostatic hypotension, and obesity. So the question is like, which of the following is not the adverse effect related to the levodopa? Anyone? Right. So the answer is obesity. Answer is the obesity. Obesity is not the feature of the it is not the adverse effect associated with the levodopa medication. Whereas the remaining all, dyskinesia, nausea, and as well as the orthostatic hypotension, they're all the features of the Parkinsonism. Sorry, they're all the adverse effects related to the levodopa, right? But not obesity. Okay, right. And associated with nausea, there can be even vomiting as well. Now, you see, whenever you abruptly stop levodopa, what can happen? You just see this question. We have a 55-year-old male with a history of Parkinson's disease, abruptly discontinues his levodopa-carbidopa therapy due to fear of side effects. Shortly after, he manifests severe muscle rigidity, hyperthermia, confusion, elevated heart rate, blood pressure fluctuation, and profuse sweating. What is the most probable condition this patient is experiencing? Wearing off phenomena, atypical Parkinsonism, serotonin syndrome, neuroleptic malignant syndrome. Very good. So it is the neuroleptic malignant syndrome. So the entire, see, any individual who abruptly stops the dopamine agonist medication, that is levodopa, carbidopa in Parkinsonism, they are at increased risk of development of the neuroleptic malignant syndrome. Now, what are the important features of the neuroleptic malignant syndrome? The important features of neuroleptic malignant syndrome, it includes the muscle rigidity, right? It includes the development of hyperthermia. There can be development of the confusion, that is altered mental status, and there can be also autonomic instability. Whatever this elevated heart rate, right, and elevated blood pressure or blood pressure fluctuations, all these are the features of autonomic instability. And this neuroleptic malignant syndrome is a medical emergency that requires immediate attention. So then how is that you will treat the neuroleptic malignant syndrome is, you need to give the following drugs. That is, dantrolene sodium is one important drug which is given in the treatment of neuroleptic malignant syndrome. And another important drug that we give in the treatment of neuroleptic malignant syndrome is the bromocriptine. So bromocriptine and the dantrolene sodium are commonly used pharmacological treatment options for the neuroleptic malignant syndrome. Okay, right. So that was the story related to the entire Parkinsonism. And you take this serotonin syndrome. Serotonin syndrome is characterized by excessive serotonin activity in the central nervous system, right? And what are the medications? What are the medications that will be causing the serotonin syndrome is, that includes serotonergic antidepressants. Right, serotonergic antidepressants, they are the one which are responsible for the development of the serotonin syndrome. Okay, and what will be the features of this serotonin syndrome? Right, right. So the important features of the serotonin syndrome, that includes agitation, confusion, muscle rigidity, hyperthermia, autonomic instability. The features will be almost resembling the neuroleptic malignant syndrome, right? That is about about the serotonin syndrome. And what are the examples of the atypical Parkinsonism? Examples of atypical Parkinsonism will be multiple system atrophy and as well as the progressive supranuclear palsy. These are the examples of the atypical Parkinsonism. And these individuals, they will have autonomic features in case of the atypical Parkinsonism, right? Then we'll see move on to the next question. Right. Yes, Vasif, I am very much interested in the results of the election, right? I have another screen adjacent to me, right? I'm just watching the election results also. Okay, right. Now, after the treatment for Parkinsonism, a patient develops a specific condition. What is the mechanism of action of the drug likely responsible for this adverse effects in dermatology? D2 antagonism, NMDA antagonism, MAO inhibitor, adenosine antagonist. Yes. Yeah. So we have got the correct answer from Metroy, right? That is, yes. What is the drug that is being used here? That is amantadine. Amantadine. I'll explain you everything. And what is the mechanism of action of this particular amantadine? That is the NMDA antagonism. Now, what is the description here? Description of the skin manifestation is, it is, you can just observe very clearly, it is purplish red and net-like, purplish red, net-like blotchy spots on the skin. Purplish red, net-like blotchy spots on the skin, right? And that is due to the reduced blood flow in the skin capillaries. And which particular drug is associated with the skin abnormalities? That is amantadine, which is an antiviral drug, which is given as a part of the treatment for the Parkinsonism. Okay, so this amantadine is associated with this skin abnormality, which is called as the libido reticularis. Libido reticularis. And what is the mechanism of this amantadine? That involves NMDA antagonism, right? And because of this NMDA antagonism, it will affect the glutamate neurotransmission, and it has a very good efficacy in the treatment of the Parkinsonism. Okay, so that is about the NMDA antagonism associated with the amantadine. So amantadine is the one which is associated with the skin abnormalities, right? Then, what are the examples of MAOB inhibitors? The examples of monoamino oxidase inhibitors, like that includes selegiline and as well as rasagiline. They are also the one which are used in the treatment of Parkinsonism. And we don't use D2 antagonism for the treatment of Parkinsonism. We use the agonist, not the antagonist, right? And what are the examples of this adenosine antagonist? Examples of the adenosine antagonist is istradiflin, right? It is istradiflin. So this particular istradiflin, even this is also used in the treatment of Parkinsonism, right? Even this is also used in the treatment of Parkinsonism, right? But this is not associated with the development of libido reticularis. Okay, what is the dermatological side effects of this istradiflin is pruritus and as well as rash. Pruritus and as well as rash. Okay, so that was the story related to your Parkinsonism, right? The next topic for the discussion will be the meningitis. Okay, right. In meningitis, the CSF analysis is very, very important. So I will discuss about the bacterial meningitis, viral meningitis, fungal meningitis, tubercular meningitis, then lumbar puncture, its contraindication. All these I'll be discussing, and the respective treatment. Next. A 25-year-old patient presents to the emergency department with fever, severe headache, and neck stiffness. Lumbar puncture is performed to collect the CSF for analysis. Which of the following CSF finding is typically observed in bacterial meningitis? Right, great. So the answer is the turbid CSF. The opening pressure in case of bacterial meningitis, it is increased. The glucose level will be reduced in case of the bacterial meningitis. And you don't have the lymphocytic predominant, you have the neutrophilic predominant, right? Neutrophilic predominant. Yeah, VPR, just give me some time, VPR. I'll come to that atypical Parkinsonism also. We have some questions on atypical Parkinsonism. I'll discuss that. Okay. right? So this will be the picture in case of the bacterial meningitis, right? And in case of the bacterial meningitis, not only in bacterial meningitis, you need to be aware of the CSF picture in all the forms of meningitis, including Guillain-Barre syndrome. So the normal CSF pressure, it is around 50 to 180 millimeters of water, right? In acute bacterial meningitis, the CSF pressure is increased. And in all the forms of meningitis, CSF pressure will be increased, except in case of Guillain-Barre syndrome. And the color of the CSF normal, it is like completely like water. It is like clear. Whereas in acute bacterial meningitis, it is like turbid. Whereas tubercular meningitis, it will be like straw colored, right? Viral meningitis, the CSF will be clear. And even in fungal meningitis also, the CSF will be clear. Whereas in Guillain-Barre syndrome, it will be normal. And if you take the cellular component, you have 0 to 4 cells per cubic millimeter in a normal individual. And that too, they are of lymphocytic predominant, right? And acute bacterial meningitis, it is neutrophilic predominant, then lymphocytic predominant in all. Metro, you did not mug up this. I'll tell you the clue for this. Okay, you take the pressure. Any form of meningitis, the CSF will not be absorbed, so CSF pressure will be increased. That is a very important concept. You take the color. Normal CSF, it is like colorless. Whereas in tubercular meningitis and bacterial meningitis, you have the inflammatory infiltrates in excess quantity. That is the reason why they are turbid and as well as straw colored. And in bacterial meningitis, it is mainly acute form of meningitis. It is an acute inflammation. That is the reason why it is neutrophilic predominant. Whereas the remaining all, it is chronic inflammation. So lymphocytic predominance. Then you take the glucose levels. The glucose level will be 2/3 of the blood glucose level. And all these inflammatory cells, they will try to utilize the glucose for their replication. All these organisms, they will utilize the glucose for their growth. So the glucose will be reduced in all these, except in case of the viral meningitis. And you take the proteins. The proteins, they are elevated in all the forms of meningitis. Normal is how much? 15 to 45 milligrams percentage. Whereas in all the forms of meningitis, the proteins are elevated. Why? Because the antibodies are formed against these organisms. And antibodies are what? Antibodies are proteins basically. So that is the reason why the proteins within the CSF, they are elevated. That is a concept there. And in case of GBS, you have an important CSF abnormality, that is albuminocytological dissociation. So albuminocytological dissociation is that where the albumin levels will be very high then compared to that of the cellular component. So this is how, right. Thank you very much, Dinesh. Yes, Metroid, did you understand the concept here? You need not mug up this table. Everything is like completely conceptual here. Okay, right. And can anyone tell me what is the differential diagnosis for the albuminocytological dissociation? The differential diagnosis for the albuminocytological dissociation is the Freund syndrome. Right? It is the Freund syndrome. Okay. So Freund syndrome is what? It's a tumor block. It's a spinal block secondary to tumor. So that is about the story related to the CSF picture in various forms of meningitis. Now, you take the question related to the treatment of bacterial meningitis. We have a 2-month-old infant. He is brought to the pediatric emergency department with fever, irritability, and poor feeding. The infant's mother reported that the baby has been lethargic and difficult to console. Suspecting acute bacterial meningitis, physician plans to initiate the antibiotic therapy promptly. Which antibiotic regimen is most appropriate in the initial treatment of this particular baby? Yeah, what is that you want to start? Right. So some of you have answered like ampicillin plus cefotaxime, and some of you have answered ampicillin plus ceftriaxone. Okay. Now, what is the age of the baby? Age of the baby is like 2 months, right? So the children of age less than 3 months, children of age less than 3 months, the common organism that will be causing meningitis will be Listeria monocytogenes. right? Listeria monocytogenes. And for Listeria monocytogenes, the very important antibiotic which is required to be given is the ampicillin. It is ampicillin. Okay. So, like in this ampicillin, you have two options, B and as well as C, and okay, even three options, B, C, and D. First option is ruled out because we definitely require the ampicillin to be supplemented. Okay, and this ampicillin is not only effective against Listeria monocytogenes, it is also very much effective against the group B streptococcus also, which is the common organism that will be causing meningitis. Now, you take whether to give cefotaxime or whether to give the ceftriaxone. Now, please remember, ceftriaxone, it is not used in children, right? Not used in children. Why? Because this ceftriaxone, it has the risk of development of jaundice in the infants. That is the reason why we don't use ceftriaxone in the infants, right? Then what is that we use in infants? That is ampicillin plus cefotaxime. Ampicillin plus cefotaxime. Okay. Whereas you take fourth option, ampicillin, cefixime, and vancomycin. That is the one which will not provide adequate coverage for the likely pathogens in infants of age group less than 3 months of age. Okay. So the correct answer is the ceftriaxone and as well as, the correct answer is ceftriaxone and cefotaxime. Cefotaxime is the one which can be given comfortably in children of age group less than 3 months. So the answer is B here, right? So it is not C. We don't give ceftriaxone in babies. That is associated with the development of jaundice. This is a very, very important take-home message here, right? Yeah. Now, if you take the age-wise, like the most common organism that will be causing meningitis, that is another very, very important question. Like the age-wise, what are the common organisms that will be causing meningitis? You take in case of the neonates. In case of the neonates, the common you take the Indian scenario. You take the Indian scenario. It is the Klebsiella and as well as the Escherichia coli and as well as the Listeria. These are the common organisms that will be causing meningitis in the neonates. Whereas you take in case of children and as well as adults. In children and as well as adults, the common organism that will be causing meningitis will be strep pneumonia. That will be strep pneumonia that will be causing meningitis. Okay. Right. So this is about the story related to the treatment in case of, whereas in adults, what we give vancomycin and as well as ceftriaxone in adults as a empirical antibiotic treatment for bacterial meningitis. Right. Can anyone identify what exactly is this in case of the tubercular meningitis? Yeah, Dr. Philadelphia, in HIV, it is the cryptococcal meningitis, right? So this is the cobweb coagulum, right, in tubercular meningitis. Now, what does this cobweb coagulum contain? This cobweb coagulum, in case of tubercular meningitis, it contains the presence of the proteins. It contains the presence of the proteins. That is what the cobweb coagulum in case of tubercular meningitis contain, right? Then, followed by that, yeah, can anyone identify what exactly is the name of this particular lesion in case of tubercular meningitis? So this particular focus, this is called as the rich focus. This focus is called the rich focus. Rich focus is observed in case of the tubercular granuloma, right? Observed in, this is tubercular granuloma. This occurs within the cortex, and this tubercular granuloma, whenever it ruptures into the subarachnoid space, that will result in the tubercular meningitis. Okay, that is nothing but rich focus. Why is it called rich focus? That is because it is named after a pathologist who has identified this first, that is Arnold Rice Rich in Johns Hopkins Hospital. That is the reason why it is called rich focus. Okay, and in case of the tubercular meningitis in children, right, in tubercular meningitis in children, you need to know this very important sign that is called Massivan sign. What is this Massivan sign? Massivan sign is that Like you do the percussion of the skull on one side, you will listen an amplified sound on the opposite side. You will listen an amplified sound on the opposite side. That is what is called as the Massivan sign. And what is the importance of the Massivan sign? It is indicative of the sutural separation. It is indicative of the sutural separation. That is what is called the Massivan sign, right? Yeah. Right. Why there will be sutural separation? That is because of the hydrocephalus, right? That is one of the complications in case of meningitis, right? Then, coming to the next question. A 45-year-old patient presents to the emergency department with altered mental status, fever, and focal neurological deficit. The physician suspects viral encephalitis and performs lumbar puncture to collect the CSF for analysis. Which of the following findings would suggest the diagnosis of the traumatic lumbar puncture? Findings suggestive of traumatic lumbar puncture. Right. So the point to tell that it's a traumatic lumbar puncture. Okay. So we have the correct answer from learner, your drug of choice. Right. So the correct answer is gradual disappearance of the RBC in second and third CSF tube. So bloody appearance in the CSF, it can be seen in other conditions also, like viral meningitis. Okay. So the presence of the RBC in the CSF, that is due to blood contamination. This could be due to subarachnoid hemorrhage. This could be due to trauma, right? That is traumatic lumbar puncture, right? And this could be even due to the viral meningitis. Even due to viral meningitis. But to tell that it is the traumatic lumbar puncture, how is that you will be able to make out? There is gradual disappearance of the RBCs in the second and third CSF tube. That is how you will be able to identify it is a traumatic lumbar puncture. Okay. If there is uniform presence of the RBCs in all three sequential CSF tubes, that might be suggestive of subarachnoid hemorrhage. Right? And bloody appearance of the CSF does not rule out subarachnoid hemorrhage from the traumatic lumbar puncture. Okay. And the last one, detection of the PLED, that is periodic lateralized epileptiform discharge on the EEG. Now, in which condition you will have this particular PLED? Anyone? In which condition you have this periodic lateralized epileptiform discharge on the EEG? Any one of you? That is observed in case of HSV1 infection. That is observed in case of the HSV1 infection. Okay, which will cause what? The viral encephalitis. It will cause the viral encephalitis. Now, if you take the quick discussion related to the viral meningitis, what is the most common virus that will be causing the viral meningitis? That includes the enterovirus. Whereas, if you take the most common cause of the viral encephalitis, that will be Japanese bee encephalitis. That will be Japanese bee encephalitis. And when you do a lumbar puncture in case of the Japanese bee encephalitis in India, whereas globally, what is the most common organism that will be causing viral encephalitis? Globally, it is the HSV1, right? And when you do a lumbar puncture will show you the presence of the bloody CSF in the HSV1. Then what exactly is the investigation of choice for the HSV1? The investigation of choice for HSV1 is you need to do PCR on the CSF analysis. When you do an EEG will show you that there is PLED, periodic lateralized epileptiform discharge. Okay. Then what is the treatment for viral meningitis? We give acyclovir. Right. So that is about the story related to the viral meningitis. Done. Now, the next question is related to the fungal meningitis. A 60-year-old immunocompromised patient presents to the clinic with persistent headache, fever, and altered mental status. A lumbar puncture is performed and the CSF analysis revealed evidence of the fungal meningitis. What is the investigation for confirming the diagnosis of the fungal meningitis caused by the Cryptococcus species? CSF culture for Cryptococcus, CSF gram stain, CSF ELISA for cryptococcal antigen, CSF India ink stain. No, 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 no. No. I did not get the correct answer from any one of you. Right. So this is not, it is not the CSF India ink stain. I'll tell you. So the correct answer is yes. Vijay Prabhu Kumar, you have answered it correctly. That is CSF ELISA for cryptococcal antigen. The investigation of choice for confirming the diagnosis of the fungal meningitis, that is Cryptococcus species, is the cryptococcal antigen. You need to do the CSF ELISA for cryptococcal antigen. And we have two species. One is the Cryptococcus neoformans. And the another important species will be the Cryptococcus gattii. Right, the Cryptococcus gattii. So these are the two important species, right? Then you take the culture. The CSF culture can confirm the presence of the Cryptococcus species, but this will take several days to yield the result. Okay, and this is less sensitive. This is less sensitive than compared to that of the cryptococcal antigen. So that is the reason why your first option is ruled out. And you take the second option, that is CSF gram stain. CSF gram stain, this is not specific. Right? This is not specific for the cryptococcus. Right? And it is not reliable for fungal organism in cases of the fungal meningitis. Now, what about the CSF India ink? Everyone was asking about the CSF India ink. So CSF India ink is used to stain the cryptococcus organism under the microscopy, but this is less sensitive, right? This is less sensitive than compared to that of the cryptococcal antigen. Less sensitive than compared to that of the cryptococcal antigen. So this cryptococcal antigen, this may yield false negative result. This may yield false negative result. Okay, so that is the reason why the answer is the cryptococcal CSF ELISA for cryptococcal antigen, right? So that is about the story related to. And how do you treat these patients with fungal meningitis? We give liposomal amphotericin B, right? Along with that, you also need to add the flucytosine. Okay, then how long you give this combination? That is 2 weeks. Until the CSF culture turns to be negative, we give this combination. And this combination should be followed by the supplementation of the fluconazole. And fluconazole, right, this fluconazole, it has to be given for almost 8 weeks. It has to be given for almost 8 weeks. Or you have to give fluconazole until the CD4 count has improved to more than 200. Okay, so that was about the story related to the fungal meningitis. Right. A 70-year-old patient presents with history of progressive gait disturbance, urinary incontinence, cognitive decline. The clinical presentation is suggestive of normal pressure hydrocephalus. What is the therapeutic procedure used to assess and potentially reduce the symptoms in patients with the normal pressure hydrocephalus? Therapeutic procedure used to assess and potentially reduce the symptoms in patients with the normal pressure hydrocephalus. Right. So, in case of the normal pressure hydrocephalus, we do a particular test called Fisher test. Right, we do a test called as the Fisher test. What is this particular Fisher test? The Fisher test, it is used to assess the patient's response to the CSF drainage in the normal pressure hydrocephalus. And what will be the clinical features in normal pressure hydrocephalus? They will have gait abnormality, they will have urinary incontinence, and they will have the cognitive decline. They will have the cognitive decline. So these are the three important findings that you will have in case of normal pressure hydrocephalus, right? And in case of normal pressure hydrocephalus, what is the treatment that is required is we do therapeutic lumbar puncture. We take almost 30 ml of the CSF out. And once you take 30 ml of the CSF out, that will help in improving the symptoms. That will help in improving the symptoms. Okay. And next to this particular therapeutic draining of the CSF, another important method by which you can do the treatment is the ventriculoperitoneal shunting. The CSF from the ventricles, they have to be shunted to the peritoneal cavity. So this is about the treatment in case of the treatment in case of normal pressure hydrocephalus, right? And when we for diagnostic purposes, we take 20 ml of the CSF, right? And what is the needle that is being used for doing the lumbar puncture? The needle is, this is Quincke's needle, right? Quincke's needle, right? Or Sprott's needle, right? Quincke's needle or Sprott's needle. Okay. So that is about the story in case of the treatment with the normal pressure, the hydrocephalus, right? So basically in these patients, what is that you'll have? You will be ensuring that the pressure is being released. The pressure is being released. Then while doing lumbar puncture, you need to know the contraindications for the lumbar puncture. The contraindications for lumbar puncture is if there is raised intracranial pressure, not the raised CSF pressure, raised intracranial pressure, then any bleeding diathesis, don't do the lumbar puncture. And if there is any local site infection, don't do lumbar puncture. And if there is infection with polio, don't do lumbar puncture. And if there is kyphoscoliosis, don't do lumbar puncture. So these are all the contraindications for the lumbar puncture. Okay. Role of mannitol, right? It is questionable importance. The role of mannitol in normal pressure hydrocephalus, it is of only questionable importance. Okay. So this is about the contraindications. And post lumbar puncture, one of the very important adverse effect is headache. And how do you treat this particular headache after the lumbar puncture? You need to advise the individual bed rest for almost 8 to 12 hours. And then followed by that, you need to give painkillers. Even in spite of giving painkillers, if the headache is not reducing, then in such case, we need to give intravenous caffeine. Intravenous caffeine should be given. That is considered as the drug of choice, right? So this is about the story related to how do you treat post-lumbar puncture headache. So this finishes the topic of meningitis, right? Yeah, Mohammed Jami, I already have sent this PDF on my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba. And once the session is over, I'll be sending the PDF with annotations also, right? Now, the next topic for the discussion will be migraine. So, in migraine, the treatment is very, very important. The Migraine Disability Assessment Score, this we call it as MIDAS, is evaluated based on the history of headache for how many months? 6 months, 1 year, 3 months, 1 month. No. We don't take 1 year. So in MIDAS, the history of headache is taken for the past 3 months. For the past 3 months. It is not 1 year. It is not even 6 months also. Right? And in MIDAS, you have a set of questionnaire. And each question, it is having a score ranging from 0 to 10. Ranging from 0 to 10. And accordingly, we will assess the CVRT, right? And what will be there in the CVRT? That is MIDAS 1, 2, 3, and as well as 4. MIDAS 1 is that where the score is 0 to 5. MIDAS 2, there is mild disability where the score is 6 to 10. MIDAS 3, moderate disability where the score is 11 to 20. MIDAS 4, severe disability where the score is 21 plus. That is the severe disability. That is severe disability. Okay, right. Then followed by that, depending upon the CVRT, we give the drug also. What is the drug to be given if MIDAS, if it is 21? If MIDAS is 11 to 20, what is the treatment? Right? If it is like 6 to 10, what is the treatment? Right? You see the next question. So A 25-year-old female comes to the OPD with complaints of throbbing one-sided headache. That is how the description of the headache will be there in migraine, which starts with blurred vision and nausea, followed by aversion to the light and sound, which lasts for 24 hours. The doctor examined the patient and gave the MIDA score of 22. Which of the following is the first-line treatment approach in this condition? Indomethacin, triptan, naproxen, paracetamol. Right. So if MIDAS is like 22, what it comes under? It comes under what is called the severe disability. It comes under severe disability. And when the MIDAS is, when the individual is having severe disability, the drug of choice will be the triptans. Right? The drug of choice is the triptans. So any individual with MIDAS score more than 21, with MIDAS score more than 21, you need to give sumatriptan, which is considered as the drug of choice. And this particular sumatriptan, it is available in various formulations. Mouth dissolving tablets. It is also available as the nasal spray. It is also available as a subcutaneous injector. And it is also available as a transdermal patch. These are the various ways by which the sumatriptan is being available. And if suppose if the MIDAS score is less than 20, if the MIDAS score is less than 20, in these patients, we give indomethacin. That is the COX-1 inhibitor. That is COX-1 inhibitor. Okay, right? And with COX-1 inhibitors like indomethacin, if the individual is not able to tolerate, if there is any gastritis, then we give the paracetamol. Then we give paracetamol. Okay. Otherwise, the indomethacin is given if the MIDAS score is less than 20. So this is about like severity and the treatment. Now, you take the various other variants of migraine. Match the following migraine variants in set 1 with their features in set 2. So set 1, you have ophthalmic migraine, retinal migraine, and familial hemiplegic migraine. Set 2, calcium channel defect, ptosis and squint, blindness and scotoma. Right. So the correct answer here is, yeah, very good, Vijay Prabhu Kumar. That is second option. So ophthalmoplegic migraine, you will have the ptosis and squint. And retinal migraine, they will have the blindness and as well as the scotoma. And familial hemiplegic migraine, this is due to the calcium channel defect. That is due to calcium channel defect. So I'll discuss the various forms of migraine. One is ophthalmoplegic migraine. That is mainly you'll be having third nerve palsy, right? And these patients, they recover over hours or days. And the important manifestation is ptosis and as well as squint in ophthalmoplegic migraine, and that is due to the involvement of the third nerve. Retinal migraine, this is associated with blindness, and there will be gradual resolution of the symptoms. And you have a dark spot in the vision, and that is what is nothing but scintillating scotoma. Then familial hemiplegic migraine, this is the first migraine attack that may present with hemiplegia. Right? And neuroimaging is required to rule out the cerebrovascular accidents. And this familial hemiplegic migraine, that is due to defect in the calcium channels. That is due to the defect in the calcium channels. Okay, that is about your familial hemiplegic migraine. Right? These are the variants of the migraine. Then, next important question related to the treatment itself. 28-year-old male presents to the hospital with the complaints of extreme headache with red and watery eyes 3 to 4 times a day. Each episode lasting for 20 minutes at about same hour every day for last 2 months. Which of the following should be used in the patients to prevent further attacks? Lignocaine, sumatriptan, verapamil, and as well as the aspirin. Can anyone tell me, first of all, what is the clinical diagnosis of the patient? What is the clinical diagnosis of this patient? What is the clinical diagnosis? Very good. So the clinical diagnosis, it is the cluster headache, right? So for cluster headache, like the drug which is given for the prevention, that is verapamil. Verapamil is the drug which is given for the prevention. Then what are the other drugs that need to be given for the prevention in case of the cluster headache, right? The other drugs are topiramate, which is an anti-epileptic drug, then melatonin, right? Then lithium, and we also have a monoclonal antibody, and this monoclonal antibody is galcanezumab. This is a humanized monoclonal antibody for preventing the cluster headache. Okay. Whereas you take lignocaine. Can anyone tell me in which form of headache we give lignocaine? Lignocaine, it is a drug used in the treatment of SUNCT. What is SUNCT? SUNCT stands for short-lasting unilateral neuralgiform headache with conjunctival injection and tearing. That is what is SUNCT, where we give the lignocaine. And in case of SUNCT, like there will be almost 3 to 200 episodes per day. And each episode, it will last for few seconds, 5 to 240 seconds. Okay. And this lignocaine, it is not useful for the cluster headache. And sumatriptan, if you take, sumatriptan, it is given for acute attacks of migraine, and it is also given for acute attacks of the cluster headache, right? And what about the aspirin? The aspirin, which is an NSAID used in the acute management of migraine, but not in case of the cluster headache. So in case of the cluster headache, the drugs that we give for preventing the acute attacks will be sumatriptan, right? And zolmitriptan, right? Sumatriptan and as well as zolmitriptan, and then high flow oxygen, right? High flow oxygen. Okay. So high flow oxygen, like 100% oxygen, is what we give as the part of the treatment for acute attack in case of cluster headache. And these are the drugs that we give for the prevention in case of the cluster headache. And this cluster headache, it is more common in males than females. And there will be redness of the eye, and the individual will have pain in the retroorbital area. There will be almost like multiple episodes in a day. That is about the description of the cluster headache. Then you take another important form of headache. A 50-year-old woman presents to the emergency department with the sudden onset severe headache described as the worst headache of her life. Upon examination, she appears agitated and experiencing neck stiffness. Non-contrast CT scan is being given below. Which of the following is not the cause of the condition that the patient is suffering from? So the entire clinical picture is suggestive of what? Question asked is not a cause of the condition that the patient is suffering from. Right. The entire clinical picture is suggestive of the subarachnoid hemorrhage. That is the worst headache of the life. And non-contrast CT scan showing the presence of the blood within the sylvian fissure, presence of the neck stiffness. All these are the points suggestive of subarachnoid hemorrhage. And right. And in case of the subarachnoid hemorrhage, the first line investigation is non-contrast CT, right? But what is the most common cause? Most common cause of subarachnoid hemorrhage is trauma, that is head trauma, followed by that the rupture of Berry aneurysm. Followed by that rupture of Berry aneurysm. That will be the second most common cause. And even arteriovenous malformations will also cause subarachnoid hemorrhage. And even Charcot-Bouchard aneurysm will also cause the subarachnoid hemorrhage. Now, what is this Charcot-Bouchard aneurysm? Charcot-Bouchard aneurysms, these are minute aneurysms or microaneurysms in the brain, right? Minute aneurysms or microaneurysms within the brain, right? And where are these microaneurysms? They are in small penetrating blood vessels, right? They are in the small penetrating blood vessels. So in the penetrating blood vessels, the microaneurysms which are developing, that is what is nothing but your Charcot-Bouchard aneurysm. But remember, and these aneurysms, whenever they rupture, that will result in the development of subarachnoid hemorrhage. But diabetes mellitus, this is not the cause. This is not the cause for the development of the subarachnoid hemorrhage. Okay. So this is about the story related to the etiology of the subarachnoid hemorrhage, right? Now, you see another important question. We have a 60-year-old female presenting to the emergency department with sudden onset severe headache, vomiting and loss of consciousness. CT scan revealed the presence of the subarachnoid hemorrhage. An ECG is performed as a part of the initial evaluation. Which of the following is not the ECG finding seen in this patient? STT depression and T-wave inversions are seen. Peaked and inverted T-waves may also be seen. QT prolongation, narrow QRS complex. So basically, this question is about like ECG changes in subarachnoid hemorrhage. ECG changes in subarachnoid hemorrhage. The question asked is not an ECG finding. Right, very good, Alok. So in patients with subarachnoid hemorrhage, there will be raised intracranial pressure. Thereby, there can be ST depression and T-wave inversion. There can be peaked and inverted T-waves may also be seen. And that we call it as global T-wave inversion. And there will be also QT prolongation. There will be also QT prolongation. But what is that you will not observe in the ECG is you will not have narrow QRS complexes in patients with raised intracranial pressure. These patients will have broad QRS complexes. These patients will have broad QRS complexes. That is about the treatment in case of, that is about the ECG changes in case of raised intracranial pressure and yeah, what are the reasons for the ECG changes? The reasons for these ECG changes is whenever there is raised intracranial pressure, there will be activation of an important reflex that is called Cushing's reflex. Right? And because of the activation of this particular Cushing's reflex, the activity within the heart gets completely altered, and that will be resulting in the ECG changes within the heart, okay, which is nothing but your Bain-Bridge reflex, right? Next, now you take the severity of the headache. Which of the following is the grade of Hunt-Hess scale when the patient has the severe headache? Grade 1, 2, 3, 4. Right? Just severe headache is there. Now, it is not grade 3. So this is grade 2. This is grade 2. Okay, why? I'll tell you. So patient is having severe headache, right? And this is being classified under grade 2 of the Hunt-Hess scale. And grade 2 indicates moderate to severe headache without a neurological deficit. Right, without neurological deficit. Okay, that is what is your Hunt-Hess scale. I'll show you the table of the Hunt-Hess scale. Mild headache, grade 1, where the GCS is 15, no motor deficits. Severe headache, grade 2, no motor deficits. Whereas, along with headache, if there is the individual, if the individual is in a state of confusion, then it is grade 3. The individual in stupor, grade 4. Individual comatose, grade 5. Okay. And in grade 3, you will have motor deficits. Grade 4 and grade 5, it is plus or minus the presence of the motor deficits. That is about the Hunt-Hess scale for the headache. Now, let me discuss the treatment of the subarachnoid hemorrhage. We have a 55-year-old male patient presents to the emergency department with sudden onset severe headache, nausea, and vomiting. CT scan of the head reveals the evidence of subarachnoid hemorrhage. Which of the following is not useful in the management of these patients? Steroid, labetalol, nimodipine, aneurysmal clip. Right, very good, Alok. So in case of subarachnoid hemorrhage, there is no role of the steroids. Okay, so these steroids, they do not provide any significant benefit. And in fact, they increase the complication of the underlying disease. So these particular steroids are not prescribed in case of subarachnoid hemorrhage. Whereas labetalol is what? Labetalol, it is both alpha plus beta blocker, right? And this particular labetalol, it is required to control the blood pressure and thereby reduce the risk of the rebuilding. Right? Thereby reducing the risk of rebuilding. That is the advantage of giving the labetalol. Whereas nimodipine is what? Nimodipine, it's a calcium channel blocker. And it is specifically indicated, right? It is specifically indicated for the prevention and treatment of cerebral vasospasm. specifically indicated for the cerebral vasospasm. Okay, because these patients, they will have compensatory cerebral vasospasm. Now, to prevent that compensatory cerebral vasospasm, we give calcium channel blockers. And the aneurysmal clip, that is mainly for the treatment of the berry aneurysms. Okay, so this is the treatment of the subarachnoid hemorrhage, right? And what are the drugs that are not given in the management of subarachnoid hemorrhage? Steroids we don't give, and antifibrinolytics we don't give. We don't give papaverine also. We don't give papaverine also, right? Yeah, see, for vasogenic edema, for vasogenic cerebral edema, steroid is one part of the treatment. Steroid is one part of the treatment for the vasogenic cerebral edema, right? But not in case of the subarachnoid hemorrhage. Okay. Then, which of the following is the least common type of primary headache in males? Least common type of primary headache in males. No, I did not get the correct answer from any one of you. Right. Alok has answered now. So the answer is the cluster headache. Okay, cluster headache. So if you take in males, what is the most common type of primary headache? That will be tension headache, right? Then followed by that, the migraine. Then followed by that, the cluster headache. Okay. Actually, if you take cluster headache, it is commonly present in both males and females. Cluster headache is observed both in males and females, right? But this cluster headache, this is more common in males rather than females. But in males, the cluster headache will be the least common cause, least common primary cause for the headache. Whereas in females, what is the most common cause of headache? That is tension headache. Then followed by that, migraine. Then followed by that, migraine. Okay. So, right. So the answer here is the cluster headache here. Next one. So that was about the story related to the topic of migraine and as well as the headache. Next, we will take up the discussion of the epilepsy. Epilepsy. Okay. A 48-year-old male presents, right, male patient presents to the emergency department with complaints of 2 episodes of the unprovoked seizures within the last 2 days. While he is in the hospital, he starts seizing. IV access is not yet obtained. What can be given to control his seizures? IM lorazepam, subcutaneous phenytoin, rectal diazepam, intranasal midazolam. Right. So the patient here is having seizures and you are not able to get the IV access. Then, yeah, so the answer here is the rectal diazepam. So rectal diazepam is the one, if you are not able to get the IV access, that is the well-established route for terminating the acute seizures. Right, for terminating the acute seizures, rectal diazepam should be given. Okay, this diazepam, it will rapidly cross the blood-brain barrier and it will exert the anti-epileptic effect. Actually, the preferable route is IV. But if you are not able to get the IV route, then the next preferable route will be rectal diazepam. Whereas the intramuscular diazepam, right, it has a very slow onset of action. So intramuscular diazepam, it is not the preferred route. Then subcutaneous phenytoin. See, phenytoin, it is not the drug which can be given for the acute seizure management. Okay. And the intranasal midazolam, yes, we give, but the intranasal route is not the preferred route, either IV or the rectal. So the answer here is the rectal diazepam, where there will be quick onset of the action. That was about like how you treat the acute seizures. Now, you see another question. Now, this is the, okay. 7-year-old boy is brought to the OPD due to recurrent 3 to 4 minutes episodes of facial grimacing and hand gestures over the past 2 weeks. He is non-responsive during these episodes and does not remember them afterwards. He recalls smelling kerosene before the symptoms started. After the incident, he feels lethargic and confused. What do you think is the possible diagnosis in this patient? Right. See, when I give the age group like 7-year-old boy, it doesn't mean that it is an absent seizure. All these, the seizures which are appearing in the children, it doesn't mean that it is an absent seizure. Okay, that's a wrong statement. It is not an absent seizure. So here it says, like the patient is having the facial grimacing and hand gestures. And in case of absent seizures, you don't have the mobility in the individual. They will just be having a staring look, right? They'll be just having the staring look. And there is like non-responsive and does not remember them afterwards. And after the incident, he feels lethargic and confused. Remember, in absent seizures, you don't have postictal confusion. So that will rule out your absent seizures. Atonic seizures, there will be complete loss of tone and there will be a fall in atonic seizures. And generalized tonic-clonic seizure, you will have the involuntary movement throughout the body. That is what is in case of the GTCS. Here the answer is the focal seizures with impaired awareness. Focal seizures with impaired awareness. What are the points to tell that the individual is having the focal seizure? So the presence of the kerosene smell, it signifies the aura. What this will signify? That is the aura. Aura, it is one of the very important feature in the focal seizures. Okay. And the individual is having impaired awareness. The individual is not able to recall the event, right? So this is a complex form of the focal seizure. This is a complex form of the focal seizure. And the patient is also having the automatisms. And what is that automatism which is here? That is hand gestures. What are the other forms of automatism? Lip smacking movements, chewing movements, swallowing movements, picking movements, postictal confusion, uncontrollable laughing. These are all your automatisms in case of the focal seizures. Okay. So the answer is focal seizure. Why is that I'm telling focal seizure? Because the individual is having involuntary movement only to the part of the body, that is facial grimacing and hand gesture. The patient is complaining of kerosene smell before the event, which is a form of the aura in case of the focal seizure, right? And there is postictal confusion. It's a form of the focal seizures, right? So the answer here is, yeah, what exactly is the aura? Aura is nothing but it is the event or it is a feature that will be seen in individual who is about to develop the seizures. So the aura will give you a feature suggestive of the focal epilepsy. The aura will tell that the patient will be having a seizure in next few minutes. That is what is your aura. Okay. So the answer is what? Focal seizures with impaired awareness, right? That was the story related to the focal seizures. And you need to know some important points in focal seizures that is called as the Todd's palsy. What do you understand by this Todd's palsy? That is a weakness that will be persisting in the arm after the focal seizure, right? Weakness persisting after the focal seizure is known as the Todd's palsy. And this Todd's palsy is the one which will mimic the stroke. And where will you see this Todd's palsy? In case of the focal seizures, right? Then. So we have discussed GTCS. That was our first question, acute seizure. Second question was focal seizure. And third question, yeah, Zan syndrome. Third question, Zan syndrome. What is the EEG pattern observed in patients with the Zan syndrome? Right. So, no. Yeah. So correct answer is from Sajan. So Zan syndrome is what? It is juvenile myoclonic epilepsy. In juvenile myoclonic epilepsy, what will be the EEG pattern? That is 4 to 6 hertz irregular polyspike activity. 4 to 6 hertz irregular polyspike activity. And this Zan syndrome, it is observed in the adolescents and it is characterized by a triad. You will have GTCS, right? You will have the absence seizures, right? And then the other important is bilateral myoclonic jerks, right? Bilateral myoclonic jerks. But the most common among all these will be GTCS, right? And how is that you will be able to diagnose juvenile myoclonic epilepsy? That is by 4 to 6 hertz irregular polyspike activity. And drug of choice in case of juvenile myoclonic epilepsy will be the valproic acid, right? And what are the precipitating factors, right? What are the precipitating factors in case of the juvenile myoclonic epilepsy? The precipitating factors in juvenile myoclonic epilepsy is sleep deprivation, right? Or alcohol consumption, right? Alcohol consumption. So these two are the precipitating factors for the juvenile myoclonic epilepsy. And where is that you will have 3 hertz spike and wave pattern? You will have this in case of the absence seizures. Okay, so we have discussed about the juvenile myoclonic epilepsy, focal seizures, and as well as the GTCS, right? And you see the next question. A previously healthy 24-year-old man is brought to the emergency department immediately after the episode of loss of consciousness. He fell down and lost consciousness. This was followed by 4 minutes of violent jerky movements of his arms and legs. He was confused after the episode. He has no recollection of the events. What laboratory values do you expect in this patient? Hypomagnesemia, increased serum prolactin, increased serum calcium, decreased serum prolactin. Yes. Right. So, no, not increased serum calcium. And it is not your decreased serum prolactin. It is increased serum prolactin. It is increased serum prolactin. So, immediately after an episode of a GTCS, there will be increase in serum prolactin. What is the reason? Prolactin is the hormone which is being produced by the pituitary gland. Okay. And this will significantly increase following the seizure. Why? Because this particular GTCS, the generalized tonic-clonic seizure, this will stimulate the neuroendocrine activity, right? This will stimulate the neuroendocrine activity. Okay. And the stimulation of this neuroendocrine activity is the one which will cause increased production of the serum prolactin. So increased serum prolactin, that is the feature of, that is a feature of the GTCS, right? Immediately after that. Then, yes, this is one important question. Which of the following condition is most commonly associated with Alice in Wonderland syndrome? Temporal lobe epilepsy, frontal lobe epilepsy, occipital lobe epilepsy, parietal lobe epilepsy. Yeah. So, yes. So Alice in the Wonderland, right? It is associated with what is called as the temporal lobe epilepsy, right? And what exactly is the characteristic features in case of the Alice in Wonderland? Why is it we call it as the temporal lobe? It is not parietal lobe, it is temporal lobe epilepsy, right? So it is associated with the following features like perceptual distortions, okay, where there is altered body image perception, and the individual will be in a state of hallucination, right, which is a trademark of the Alice in Wonderland. Okay, the individual will be in a state of hallucination, right? And this Alice in the Wonderland syndrome, they will also have abnormality in the individual sensory sensations. That is what is the feature of Alice in Wonderland syndrome, which is a feature of the temporal lobe epilepsy, right? Now, I'll quickly just show you this table related to the epilepsy. Yeah, please tell me what exactly is the drug of choice in case of GTCS, myoclonic jerks, atonic and absence seizures? Yeah, so this will be valproic acid. And what will be the drug of choice for febrile seizures during the episode? During the episode, it will be intranasal for febrile seizures, right? Intranasal midazolam, right? Or the rectal diazepam, right? Or rectal diazepam. And what is the prophylaxis of the febrile seizures? The prophylaxis of the febrile seizure is we give oral diazepam. And what is the treatment that we give for the absence seizures in individuals less than 4 years? Drug of choice will be ethosuximide. We don't give valproic acid because valproic acid is associated with the hepatotoxicity, right? And absence seizures more than 4 years, here we give the valproic acid. And for infantile spasms, the drug of choice will be the ACTH. And for infantile spasms in tuberous sclerosis, drug of choice will be vigabatrin. And for status epilepticus, the drug of choice is lorazepam. And for juvenile myoclonic epilepsy, the drug of choice is the midazolam. I'm sorry. For juvenile myoclonic epilepsy, it is valproic acid. Okay. Right. So this is about the story related to the treatment. Yeah, yes, Vijay Prabhukumar. That is a new molecule which has come up. That is for the prophylaxis, the NOT clobazam has been given. Right. It is not the clobazam. It is the oral diazepam. It is the oral diazepam for the prophylaxis of the febrile seizures. It is not the clobazam. Now, if the individual is having medically refractory epilepsy, right? Medically refractory epilepsy, we give ketotic diet, right? Then vagal nerve stimulation, right? Then, yeah. Now, next topic is multiple sclerosis and neuromyelitis optica, right? Please answer this question. All are included in the pathophysiology of multiple sclerosis except myelin damage, axon damage, cells involvement, Schwann cell response, except. So in case of multiple sclerosis, right, very good, Bhuvan Aragu. So Schwann cell response will not be there in case of the multiple sclerosis. So multiple sclerosis, which is a disorder where you have abnormality within the immune system, right? There is myelin damage, there is axon damage, and there will be also inflammatory cell involvement. And what is that inflammatory cells? That is mainly the B cells, right? That is mainly the B cells. Okay, but you don't have the involvement of the Schwann cell involvement, right? Then, and they will also have the oligodendrocyte response. Now, that was about the pathogenesis in case of multiple sclerosis, which is an immune-mediated attack. Next is you take the clinical features in case of multiple sclerosis. A 45-year-old male presents to the neurology clinic with complaints of shooting pain radiating down his legs upon flexing his neck forward. The patient reports experiencing this symptom intermittently over the past few weeks, particularly when bending his neck forward or looking down. On examination, the neurologist elicits the Lermite sign. This is seen in all of the following except. Question asked is except. Right. The question asked is except. So you don't have the Lermite sign in case of neuromyelitis optica. Tabes dorsalis, which is secondary to the syphilis, then cervical spondylosis, then multiple sclerosis, you have the presence of Lermite sign, but not in neuromyelitis optica, right? And the another name for Lermite sign is what? It is also called as the Bulbar chair sign. It is also called Bulbar chair sign. And there are multiple other conditions where you will have this Lermite sign. These are all the conditions where you will have the Lermite sign, right? Demyelination, head and neck radiotherapy, subacute combined degeneration of the spinal cord, vitamin B12 deficiency, trauma or compression to the cervical myelopathy, right? Radiation, pyridoxine toxicity, SLE, cavernous angioma, right? Now, all of the clinical features of the multiple sclerosis except internuclear ophthalmoplegia, 1.5 syndrome, 8.5 syndrome, detrusor hyporeflexia. Yes. So you don't have the detrusor hyporeflexia. What is that you will have is detrusor hyperreflexia will be there. In multiple sclerosis, you will have detrusor hyperreflexia, right? And the internuclear ophthalmoplegia, it is one of the very important feature of multiple sclerosis, and that is due to lesion in the median longitudinal fasciculus, right? And in internuclear ophthalmoplegia, there will be horizontal gaze palsy in one direction, right? So there will be horizontal gaze palsy in one direction, and ipsilateral internuclear ophthalmoplegia will be there. And what is this 1.5 syndrome? 1.5 syndrome is that where the movement of one eye is completely lost, right? Movement of one eye, it is like completely lost, okay? And in the other eye or in the opposite eye, there will be only partial inability to move. Right? There will be only partial inability to move the other eye. That is only half. That is why it is called 1.5 syndrome. Then what is 8.5 syndrome? In 8.5 syndrome, the seventh nerve will be paralyzed. Along with that, you have the 1.5 feature. This will become 8.5. Okay, there will be seventh nerve palsy. Along with that, 1.5 will be there. That will be 8.5. And detrusor hyporeflexia will not be there, and detrusor hyperreflexia will be there in these individuals. Okay, so that was about the clinical. And what is the most common cranial nerve which gets affected in case of multiple sclerosis? That is the optic nerve. The optic nerve is the most common cranial nerve which gets affected, and many other cranial nerves. There will be demyelination of the fifth nerve, sixth nerve, seventh nerve, eighth nerve, ninth nerve in case of the multiple sclerosis. What is the investigation of choice? The investigation of choice will be MRI, where you have the presence of the Dawson's fingers. And these Dawson's fingers are nothing but the plaques which are present in the periventricular area. And when you do a lumbar puncture, the lumbar puncture will show you the oligoclonal bands, right? And when you do a visual evoked potential in multiple sclerosis, there will be reduced amplitude of the voltage which is generated within the optic nerve, right? So that was about the investigation. And what is the criteria that is being followed? That is McDonald's criteria for diagnosing the multiple sclerosis, right? Next, coming to the treatment of multiple sclerosis. Which of the following is the side effect of the natalizumab that is used in the management of multiple sclerosis? Thrombocytopenia, neutrophilia, neutropenia, progressive multifocal leukoencephalopathy. Right, so that is the progressive multifocal leukoencephalopathy. So what is the drug of choice in acute episodes? In acute episodes for multiple sclerosis, the drug of choice will be, we give methylprednisolone. That is a drug of choice. Okay. Also, whereas you take the disease-modifying drugs. Disease-modifying drugs are the one which will prevent the relapse, which will give as the maintenance therapy. So the examples will be the beta interferons, right? Then natalizumab. Then we have the glatiramer acetate. But this particular natalizumab, whenever you are giving these individuals, they are at increased risk of development of the progressive multifocal leukoencephalopathy. And the other drugs are fingolimod. The other drugs are like dimethyl fumarate. These are the drugs which are given in the treatment of the multiple sclerosis. Okay, these are like for maintenance therapy. Acute episode, it is methylprednisolone. That is about the story of the treatment of multiple sclerosis. And you see this very important question. We have a 32-year-old female presents to the neurology clinic and reports experiencing severe eye pain and blurred vision in her right eye over the past week, accompanied by difficulty in walking and as well as difficulty in coordination. On examination, patient demonstrates decreased visual acuity in the right eye along with relative apparent pupillary defect and optic disc edema on the fundoscopic examination. Additionally, she exhibits spasticity and hyperreflexia in her lower limbs. Which of the following will not be seen in this patient? acute post-trauma syndrome, acute brainstem stroke syndrome, optic neuritis, retinal detachment. So can anyone tell me what is the diagnosis of this clinical scenario? What will be the diagnosis of this clinical scenario? Yes. So the diagnosis of this clinical scenario will be neuromyelitis optica. The diagnosis of this clinical scenario is neuromyelitis optica. So in neuromyelitis optica, you have all these features. You will have the involvement of the optic nerve and as well as the spinal cord. Because of the involvement of the optic nerve, you have this blurred vision and you will have this relative apparent pupillary defect and the optic disc edema. And why is it they have this hyperreflexia in the lower limbs? That is due to the involvement of the spinal cord. There will be almost involvement of more than two segments of the spinal cord, and that will result in the hyperreflexia. And in patients with neuromyelitis optica, right, you'll have area post-trauma syndrome, there will be acute brainstem stroke syndrome, and there will be optic neuritis, but retinal detachment, that is not the feature of the neuromyelitis optica, right? And how do you treat these patients with the neuromyelitis optica is the drug of choice for neuromyelitis optica is methylprednisolone, right? And we can also do the plasmapheresis as a secondary treatment option. So that was about the NMO, right? And okay, one last question related to the cerebrovascular accidents. Last question. Lacunar stroke is seen due to damage of the lenticulostriate branches. Which are the branches which are damaged? Horizontal branch of middle cerebral artery, insular part of middle cerebral artery, opercular part of middle cerebral artery, cortical part of the middle cerebral artery. Right. So for the development of the lacunar stroke, the part which is being affected is it is the horizontal part of the middle cerebral artery. So horizontal part of the middle cerebral artery, what exactly is that? It is M1. If you see the division of the middle cerebral artery, right? If you see the divisions of the middle cerebral artery, we have M1, M2, M3, and M4. M1 is horizontal part, M2 is insular part, M3 is opercular part, M4 is the cortical part. Now, in order to develop the lacunar stroke, which part has to be affected is the horizontal part of the middle cerebral artery is the one which is being affected for the development of the lacunar stroke. Okay. And what are the risk factors for the development of the lacunar stroke? The risk factors for the development of the lacunar stroke, that includes the hypertension, that includes diabetes mellitus, that includes smoking, that includes atherosclerosis. Right? So this is about the quick revision of the entire neurology topic. This is the quick revision of the entire neurology topic, right? So you just take a break now, right? We will come back and discuss the questions on, the quick revision on the nephrology. We will do quick revision of nephrology. So this nephrology will be there for 1 hour, right? And subsequently, we will see the others, right? So just take a break for 15-20 minutes. Then we will be back and discuss the remaining topics. Mainly, we will be discussing the nephrology, right? Right. So, right. So if you see the discussion of the nephrology, like we'll just wind up this immediately. So the question is, which of the yeah, which of the following complications is most likely to develop in a patient with chronic kidney disease classified as the stage 4? Yes. So in case of the stage 4 or grade 4, the complication that is very commonly observed is the hyperkalemia. Now, if you take the CKD, like you have the CKD grade 1, 2, 3, 4, and 5. And that is based on the GFR. And in grade 1, the GFR is like more than 90. Whereas in grade 2, the GFR, it is like 60 to 89. Whereas in grade 3, the GFR is 30 to 59. Whereas in grade 4, the GFR is 15 to 29. And less than 15 will be grade 5. Okay. Now, you take the hyperkalemia, it is observed in case of the grade 4. Then what about the other options? You take hypertension. Hypertension is observed in grade 2 of this chronic kidney disease. And what about anemia? Anemia is observed in grade 3. Hyperkalemia is observed in grade 4. Uremia, it is observed in grade 5. Uremia is observed in grade 5. Okay. So the answer is grade 4. And that is hyperkalemia. And what exactly is the drug of choice for hyperkalemia? We give calcium gluconate as the drug of choice. And what are the other drugs that we give in case of hyperkalemia is insulin plus dextrose. We give salbutamol nebulization. Then we also give furosemide, and we give the potassium binding agents like sodium polystyrene sulfonate. Okay. And in refractory cases, we do dialysis. So that was about the hyperkalemia in grade 4. Then, yeah. So pick the option with appropriate statement regarding the allogenic kidney transplantation. So prior Doppler showing unilateral renal artery stenosis in the donor is a contraindication. Right kidney of the donor is used. The donor's kidney is placed in the right iliac fossa of the recipient. Recipient with 1/6 HLA match anti-CD25 molecule is used for induction. So what do you think is the correct statements? Right. So the correct answer here is your A. Prior Doppler showing unilateral renal artery stenosis, it is contraindication for the donating the kidney. And next, donor kidney, it is placed in the right iliac fossa of the recipient. So these 2 points, A and C, are correct. And it is not the right kidney of the donor, it is the left kidney of the donor is being taken. And when will you start this anti-CD25 molecule for the induction therapy? And what is the example of that anti-CD25? That is basilixumab. That is a treatment. And we give this basilixumab when there is 3/6 HLA match, not 1/6 HLA match. So your B and D, they are the incorrect points. Whereas A and C, they are the correct points. Okay. One last question, we will just wind up this session. Which of the following is not true regarding the procedure shown in the image? Refractory acidosis is an indicator for this therapy. The presence of bruit indicates a damaged fistula. The presence of the diffusion, the principle is diffusion followed by ultrafiltration. Seminobraccia fistula is between the radial artery and cephalic vein. Not true. So the incorrect statement is refractory acidosis is what is the treatment being done here? Hemodialysis. In refractory acidosis, we do hemodialysis, right? And what is the principle in hemodialysis? That is diffusion followed by ultrafiltration. And seminobraccia fistula is the one which is connected between the radial artery and as well as the cephalic vein, right? And the presence of bruit, it indicates damaged fistula. It is an incorrect statement. The presence of the bruit, it indicates that there is a functional fistula. It is not a damaged fistula, right? So this is about the question related to the hemodialysis, right? So we will just wind up the session here. I'll be sending these PDFs on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, right? So thank you very much and see you. All the best.